It is 11:30 at night. You have eaten dinner. Nothing extravagant, nothing unusual, the same kind of meal you have had 100 times before. Maybe pasta, maybe a salad with some beans, maybe just a piece of bread and soup. And now you are sitting on the couch or lying in bed, and your stomach looks like you swallowed a basketball. The pressure builds from the inside, slow and insistent, like someone is inflating a balloon beneath your ribs. You shift positions. You try lying on your left side, then your right. You press gently on your abdomen, and it feels tight and almost drum-like. The discomfort is not quite pain. It is something harder to describe, a fullness that does not belong, a pressure that makes you feel both trapped inside your own body and faintly ridiculous for not being able to explain it to anyone. You have been to the doctor, maybe more than once. They pressed on your abdomen, asked if it hurt, ordered some blood work, told you to try cutting out gluten or dairy, or maybe to add more fiber. Maybe they handed you a pamphlet about irritable bowel syndrome, and the bloating came back anyway, because it always does. Here is the thing they did not tell you, and that is why you are here. That bloating is not normal. It is not just something you have to live with. It is not simply a quirky digestive personality. It is a signal, and in many cases, it is a very specific signal pointing to a very specific problem that the standard 7-minute appointment was never going to uncover. Today, we are going to follow that signal all the way to its source. We are going to talk about a condition called Small Intestinal Bacterial Overgrowth, a mouthful that most physicians either do not test for, do not recognize, or both. We are going to talk about what is actually happening inside your gut when that balloon inflates. We are going to talk about the hidden connection between your bloated stomach, the brain fog that makes you feel like you are thinking through wet concrete by 3 in the afternoon, and the fatigue that no amount of sleep seems to fix. And we are going to give you a real protocol, not vague lifestyle advice, but actual specific step-by-step guidance you can start this week. Subscribe to Dr. Cross and hit the notification bell. We are building this channel one honest conversation at a time, working toward 1,000 subscribers. Every single one matters because it means one more person gets information they will not hear in a waiting room. Now, let us start with the thing that almost everyone has gotten wrong. For years, the standard narrative around bloating went something like this. You eat certain foods that your gut cannot handle well. Gas is produced. You feel uncomfortable. The solution is either to avoid those foods or to accept that some people just have sensitive digestive systems. This framework is not entirely wrong, but it is so incomplete that following it alone is like trying to fix a broken engine by changing the air freshener. It addresses the smell but ignores the fire underneath. The most common misconception I hear from patients, and honestly from colleagues too, is that bloating is primarily a food sensitivity problem, that the solution is simply identifying and eliminating the offending food. If you stop eating beans, the gas stops. If you cut out dairy, the pressure goes away. And for some people, in some situations, that provides temporary relief. But here is what no one is asking. Why are those foods producing this response in the first place? Because your grandmother ate lentils her whole life and never felt like she was carrying a spare tire under her shirt after dinner. So why are you? And this is where most people have been getting it wrong for years. The problem, in a huge number of cases, is not the food. The food is just the fuel. The problem is where and by whom that fuel is being burned. Under normal circumstances, your small intestine, the long, winding tube that sits between your stomach and your large intestine, is supposed to be a relatively bacteria-sparse environment. The large intestine, sometimes called the colon, is where the bacterial party is supposed to happen. Down there, in that lower portion of your gut, you have trillions of bacteria going about their business, fermenting fiber, producing certain vitamins, doing genuinely useful things. That is normal. That is supposed to happen. But here is the critical detail. When bacteria that belong in the large intestine migrate upward and set up residence in the small intestine, they start doing their fermenting work in entirely the wrong neighborhood, and the small intestine is not designed for that kind of activity.
When you eat carbohydrates,
Any carbohydrates, not just beans, not just the usual suspects, but bread, fruit, pasta, vegetables, even some proteins. Those displaced bacteria get to that food before your body properly digests it. They ferment it immediately. The byproduct of that fermentation is gas. Large quantities of gas, produced in an area of your gut that is not equipped to handle it. The result is that drum-like distension, that balloon under your ribs, that pressure that arrives almost before the meal is finished. This is small intestinal bacterial overgrowth, SIBO for short, and the research on how common it is should genuinely disturb you. Because, depending on the study and the population being examined, it is estimated to be present in somewhere between 6 and 15% of healthy individuals, and in up to 80% of people who have already been diagnosed with irritable bowel syndrome. 80%. That means the vast majority of IBS diagnoses, a diagnosis that is essentially a description of symptoms with no identified cause, may actually be undiagnosed SIBO that has been sitting there untreated, sometimes for years. Before we go further, I need to pause and be direct with you about something. There are symptoms that should take you straight to a doctor, not to a YouTube video. Unintentional weight loss, more than 10 pounds in a few months without trying, combined with bloating, needs to be evaluated. Bloating accompanied by blood in your stool, even a small amount, requires same-week medical attention. If you are experiencing severe abdominal pain that is getting progressively worse over hours, that is an emergency room visit, not a protocol adjustment. If your bloating is accompanied by yellowing of the skin or eyes, or significant swelling in your legs and ankles, please see a physician immediately. And if you are over 50 and have never had a colonoscopy, that conversation with your doctor should happen before anything else. I am going to give you real information today that I believe will help a great many people, but none of it replaces the evaluation of someone who can examine you in person. Please hold both of those things at once. Now, a question for you. How old are you? Drop your number in the comments. I genuinely want to know because SIBO presents somewhat differently across age groups, and I want to make sure the information I am sharing connects to where you actually are right now. After 50, the mechanisms I am about to describe become even more clinically significant for reasons we will get into. Let us talk about what is actually happening inside the body, because this is where it gets genuinely fascinating, and because understanding the mechanism is the only way to understand why the standard treatments so often fail. Your digestive system is not a simple pipe. It is an extraordinarily complex ecosystem with its own nervous system, the enteric nervous system, sometimes called the second brain, its own immune system, its own chemical communication network. The small intestine alone is roughly 20 feet long when stretched out, coiled inside your abdominal cavity, lined with millions of microscopic finger-like projections called villi. Picture a thick carpet rather than a smooth floor. These villi are where nutrient absorption happens. They are also where the first signals of bacterial overgrowth begin to cause damage. The small intestine is supposed to defend itself against bacterial colonization through several mechanisms. First, stomach acid. Hydrochloric acid, produced by the cells lining your stomach, is supposed to be potent enough to kill most bacteria before they even make it into the small intestine. Think of it as a chemical security checkpoint at the entrance. The pH of a healthy stomach at rest sits somewhere between 1.5 and 3. That is extremely acidic, roughly the acidity of battery acid, though obviously operating in a biological context. Most bacteria cannot survive that environment. They are neutralized before they become a problem. Second, something called the migrating motor complex, or MMC. This is a wave of muscular contractions that sweeps through the small intestine roughly every 90 to 120 minutes during fasting. Think of it as a slow-moving broom that sweeps bacteria, food debris, and cellular waste down and out of the small intestine and toward the large intestine where it belongs. When you are constantly eating, grazing, snacking every 2 hours, never going more than 3 or 4 hours without food, the MMC is never fully activated because it only initiates in a fasted state. The broom never runs. The bacteria accumulate. Third, something called the ileocecal valve, the small muscular gate between the end of the small intestine and the beginning of the large intestine. Under normal circumstances, this valve prevents backflow. It stops the dense bacterial population of the colon from migrating backward up into the small intestine. When this valve becomes dysfunctional, which can happen for a number of reasons including chronic constipation, chronic diarrhea, inflammation, or prior abdominal surgery, that bacterial border control breaks down. So what happens when these defenses fail? Bacteria move in, and they are not passive tenants. They are metabolically active. When a fermenting bacterium encounters a carbohydrate molecule, a sugar, a starch, a fiber, it does not wait for your body to process it first. It processes it immediately, right there in the small intestine. It produces hydrogen gas, sometimes methane gas, sometimes hydrogen sulfide, depending on the species involved. These gases accumulate in the small intestinal lumen. The pressure builds. The intestinal walls stretch. Your nervous system registers that stretch and interprets it as distension, and that is the sensation you feel. But that is only part of the story, because while all of this is happening in the lumen, the open space inside the intestine, something else is happening to the intestinal wall itself. The villi that are supposed to be absorbing your nutrients are being damaged. The bacteria in the small intestine produce substances that degrade the brush border enzymes on the surface of those villi. The enzymes responsible for breaking down lactose, fructose, certain carbohydrates, and absorbing vitamins B12 and fat-soluble vitamins like A, D, E, and K. The result is a gradual but significant impairment in nutrient absorption. You are eating, but your body is not receiving the full nutritional value of what you eat. And in chronic SIBO, this creates secondary deficiencies that manifest in ways people rarely connect to their gut. Fatigue, because B12 is essential for cellular energy production. Brain fog, because both B12 and iron deficiencies affect neurological function. Bone loss over time, because vitamin D and calcium absorption are compromised. Skin problems, because fat-soluble vitamins are critical for skin cell integrity. This brings us to one of the more remarkable aspects of SIBO, the gut-brain connection. And I want to spend some time here because I think this is the link that makes so many people's experience suddenly make sense. Your gut and your brain are in constant bidirectional communication through a highway called the vagus nerve, the longest cranial nerve in your body, running from the base of your brainstem down through your neck, chest, and into your abdomen. Roughly 80% of the traffic on this nerve runs from the gut to the brain, not the other way around. Your gut is talking to your brain far more than your brain is talking to your gut. And when the gut is in a state of chronic bacterial overgrowth, it is sending a continuous distress signal up that highway, and the brain feels it. The specific mechanism involves something called lipopolysaccharide, or LPS, a molecule found on the outer membrane of certain gram-negative bacteria. Under normal conditions, LPS stays confined to the gut. But when the intestinal lining is damaged by chronic bacterial presence, it begins to leak. LPS crosses into the bloodstream in small quantities, a state sometimes called metabolic endotoxemia, and it triggers a low-grade systemic inflammatory response. Inflammatory cytokines circulate. They cross the blood-brain barrier, and they produce exactly what researchers call sickness behavior: fatigue, difficulty concentrating, low mood, cognitive slowing, a feeling of being mentally and physically heavy that has no obvious external cause. If you have ever described your experience to someone as feeling foggy, feeling like your brain is running on a reduced processor speed, feeling inexplicably exhausted even after 7 or 8 hours of sleep, and had them look at you like you were dramatizing, this mechanism is likely why. The inflammation is real, the cognitive impairment is real, and it is originating, at least in part, in your gut. Now, I need to pause here because this next point is critical, and it is one of the most important things I will say today. If you go to a physician with chronic bloating and they diagnose you with SIBO, or even if you suspect SIBO yourself, there is a reflex in conventional medicine to reach for antibiotics, specifically a drug called rifaximin, which is the current gold standard pharmaceutical treatment for SIBO. And rifaximin does work in the short term for many patients. I am not dismissing it, but here is the problem that the prescription pad does not tell you. Antibiotics, including rifaximin, address the overgrowth. They reduce the bacterial population in the small intestine, but they do not fix the conditions that allowed the overgrowth to develop in the first place. They do not restore stomach acid production if that has been compromised. They do not fix a dysfunctional ileocecal valve. They do not retrain the migrating motor complex. They do not repair the intestinal lining. So what happens in a significant proportion of patients, and I have seen this clinically and the research supports it, is that SIBO recurs within 3 to 6 months of antibiotic treatment. And with each recurrence and each additional antibiotic course, the underlying bacterial ecosystem becomes further disrupted, resistant strains may emerge, and the foundational problems continue to deepen. I stopped accepting that answer years ago, and you should too. The goal is not to repeatedly eradicate the overgrowth. The goal is to restore the conditions under which the overgrowth cannot sustain itself, and that is a very different objective. Let me tell you about Priya. Priya was 44 years old when she walked into my office during my last year in Boston. She was a software project manager. Sharp, methodical, the kind of person who had already compiled a binder of her symptoms and a timeline before the appointment started. She had been dealing with bloating for 15 years. 15 years. She had been to 3 gastroenterologists. She had tried a low FODMAP diet, which gave her partial relief but never fully resolved the problem. She had tried eliminating gluten, then dairy, then both simultaneously. She had done food sensitivity panels, which came back with a list of 23 reactive foods that, when she eliminated them all, left her eating approximately 4 things and still bloating. She had been on 2 courses of rifaximin, 3 years apart. Each time, the bloating improved for a few weeks and then returned. What struck me about Priya was not what she said, but how she said it. She had the posture of someone who had been told, in various clinical vocabularies, that this was simply her lot. Her GI doctor had used the phrase sensitive gut. A naturopath had told her she had an overactive immune response to food. Her general practitioner had suggested anxiety might be contributing and had offered a referral to a therapist. None of them were entirely wrong, but none of them had looked at the whole picture. When I sat with her and went through the timeline carefully, a pattern emerged. The bloating had started in her late 20s, about 6 months after a round of antibiotics for a urinary tract infection. It had worsened significantly in her mid-30s after a bout of food poisoning on a trip abroad, and it had never fully remitted since. She mentioned almost in passing that she had been on a proton pump inhibitor, a stomach acid suppressant, for about 8 years, originally prescribed for reflux that had since mostly resolved. She was still taking it out of habit, and because no one had ever suggested she stop. That proton pump inhibitor was, in my assessment, a major driver of her ongoing SIBO. By chronically suppressing stomach acid production, she had removed the chemical checkpoint that should have been killing bacteria before they reached the small intestine. 8 years of reduced acid, 8 years of bacterial migration going relatively unchecked. The food poisoning in her 30s had almost certainly introduced a bacterial strain that, combined with already compromised gut defenses, established a persistent overgrowth pattern. And every antibiotic course had temporarily reduced the population while doing nothing to restore the acid barrier. We built a 6-week protocol around her specific situation. Within 3 weeks, Priya described her bloating as reduced by roughly 60%. By week 6, she described it as 90% improved. She told me, in a follow-up message about 4 months later, that she had eaten lentils for the first time in 11 years without any significant reaction. I am not telling you this story to oversell what is possible. I am telling it because 15 years of misery was not inevitable. It just required someone to ask the right questions. Now let us talk about the bloat timing test, because this is something you can do right now at home that costs nothing and can give you meaningful information about where in your digestive tract the problem is originating. The basic principle is simple. Different parts of the digestive system operate on different timelines. If you eat a meal and you bloat within 30 to 60 minutes, before your food has even had time to reach the small intestine in significant quantity, the problem is likely in the stomach. This pattern often points to low stomach acid or delayed gastric emptying. The fermentation is happening in or just below the stomach. If you bloat between 1 and 2 hours after eating, that timing corresponds roughly to food transit through the early to mid small intestine. This is the classic SIBO pattern. The bacteria in the small intestine encounter the food, ferment it immediately, and you are distended within an hour or two of the meal. If you bloat between 2 and 5 hours after eating, noticing that it is significantly worse in the afternoon or evening, even if you ate at midday, the fermentation is more likely occurring in the later small intestine or transitioning into the large intestine. This pattern can indicate SIBO in the terminal ileum, or it can indicate large intestinal dysbiosis, which is a different but related problem. If your bloating is almost exclusively in the lower abdomen, below the belly button, arriving 4 or more hours after eating, and often accompanied by significant gas and changes in stool consistency, the problem is more likely colonic fermentation rather than classic SIBO. Keep a simple log for 4 to 5 days. Note the time you eat. Note when bloating begins. Note the location, upper abdomen, mid-abdomen, or lower abdomen. Note the intensity on a scale of 1 to 10. After 4 to 5 days, the pattern will usually become clear. Bring that log to your doctor. It is genuinely useful information that takes you from a vague complaint to a data set, and it changes the entire nature of the clinical conversation. Let me now walk you through the protocol I have built, refined over several years of working with patients dealing with exactly this problem. I want to be transparent. This is not a pharmaceutical protocol. It is a natural antimicrobial and gut restoration protocol based on evidence that is real and published, even if it does not always make it into the waiting room visit. And I want to be equally transparent that not every approach works for every person, and that what I am sharing is educational information, not personalized medical advice. If you have significant health conditions, if you are on medications, particularly immunosuppressants or blood thinners, please work with a practitioner before making significant changes to your regimen. The first intervention is stomach acid restoration. This is foundational. If the stomach acid checkpoint is compromised, nothing else you do will fully address the problem, because the bacteria will keep migrating. The most common cause of chronically low stomach acid, a condition called hypochlorhydria, is not too much acid, which is what most people assume. It is actually a set of factors including chronic stress, which suppresses the vagus nerve activity that stimulates acid production, H. pylori infection, which directly impairs acid-secreting cells, long-term use of proton pump inhibitors, aging. After 50, stomach acid production naturally declines by a meaningful margin, which is one reason SIBO becomes more prevalent in older adults, and chronic zinc deficiency, since zinc is required for the production of stomach acid. The most effective natural approach to improving stomach acid involves 2 things used in combination. First, apple cider vinegar. Not a folk remedy. There is a legitimate physiological rationale here. 1 to 2 tablespoons diluted in roughly 8 ounces of water, consumed 10 to 15 minutes before meals. The acetic acid in the vinegar stimulates gastric acid production through a reflex pathway and may also directly lower the gastric pH, enhancing the protein digesting activity of pepsin. Use raw, unfiltered apple cider vinegar with the mother, the cloudy sediment at the bottom, since the active compounds are more concentrated. Do not drink it undiluted, and if you have known esophageal problems, check with your doctor first, because the acidity, though mild, can be irritating. Second, bitter herbs. Gentian root, dandelion root, and Swedish bitters have been used for centuries to stimulate digestive secretions, bile, stomach acid, and pancreatic enzymes. The mechanism is not mysterious. Bitter taste receptors on the tongue and in the gut trigger a cephalic phase digestive response, preparing the entire digestive system for incoming food. About 20 drops of a gentian-based bitters tincture in a small amount of water, 10 to 15 minutes before eating, taken consistently over 4 to 6 weeks, can produce a measurable improvement in digestive enzyme output and gastric acid production in people with hypochlorhydria. The second intervention is activating the migrating motor complex. Remember the broom analogy, the wave of muscular contractions that sweeps bacteria out of the small intestine during fasting states. You cannot swallow a pill to fix this. You have to create the conditions for it to operate. The single most important thing you can do is establish meal spacing of at least 4 to 5 hours, with no snacking between meals. I understand this is a significant adjustment for many people, particularly those who have been told that frequent small meals are healthier. For some conditions, frequent small meals make sense. For SIBO, they are deeply counterproductive. Every time you eat, even a small snack, the MMC resets to 0. The broom does not run. Give your gut the fasting window it needs to clean house. Additionally, ginger has clinically documented prokinetic effects, meaning it stimulates the movement of food and bacteria through the gastrointestinal tract. A simple preparation of fresh ginger tea, made from roughly 1 inch of fresh ginger root grated into 2 cups of just boiled water, steeped for 15 to 20 minutes, then strained, consumed once or twice daily between meals, can genuinely accelerate gut motility. If you want to quantify this in practical terms, research on ginger and gastric emptying rate suggests it can reduce gastric emptying time by roughly 25 to 30% compared to control. That means food is moving through the upper digestive tract faster, spending less time in the bacterial danger zone. The third intervention is the natural antimicrobial protocol, and this is where I want to be very specific about what the evidence shows and what it does not. The goal of natural antimicrobials in SIBO treatment is not to sterilize the gut. That would be as counterproductive as a nuclear option. The goal is targeted reduction of the bacterial overgrowth in the small intestine while minimally disrupting the large intestinal microbiome, which is vastly more complex and important. Oregano oil. The active compound in oregano oil is carvacrol, and the published research on its antimicrobial properties is substantial. A study published in the journal Frontiers in Microbiology demonstrated that carvacrol exhibited significant activity against a range of gram-positive and gram-negative bacteria associated with intestinal overgrowth. The important nuance is formulation. You need enteric-coated oregano oil capsules. This is not optional. If the oregano oil releases in the stomach, it will kill beneficial stomach environment organisms and irritate the gastric mucosa without reaching the small intestine in effective concentrations. Enteric coating ensures the capsule dissolves in the alkaline environment of the small intestine, precisely where you need the antimicrobial activity. A typical protocol is 2 capsules of enteric-coated oregano oil standardized to at least 70% carvacrol, taken twice daily with meals for 4 weeks. Do not exceed 6 weeks continuously. Cycle off for 2 weeks before repeating if needed. Berberine. This compound, found in plants including barberry, Oregon grapefruit, and golden seal, has been studied extensively. A review in the journal Phytotherapy Research noted that berberine demonstrates broad-spectrum antimicrobial activity while simultaneously having anti-inflammatory and gut barrier supportive properties. Interestingly, berberine also has a well-documented effect on glucose metabolism, which is relevant because the bacteria causing SIBO ferment carbohydrates. Reducing the glucose availability in the small intestine through berberine's metabolic effects may contribute to its anti-SIBO activity through a secondary mechanism. A standard dose is 500 milligrams of berberine hydrochloride twice daily with meals. Important caveat: berberine can interact with certain medications, including metformin and some blood pressure medications. This is one where I genuinely want you to check with your prescriber if you are on any regular medications. Allicin from garlic. Yes, garlic, but not just eating garlic. The compound allicin, which forms when raw garlic is crushed or chopped and then activates within minutes, is a potent antimicrobial. The challenge with dietary garlic is that a large portion of the allicin is degraded by stomach acid and never reaches the small intestine in active form. This is why allicin extract supplements, again in enteric-coated form, are more effective for SIBO than simply adding garlic to your cooking. Doses of approximately 450 milligrams of allicin extract twice daily have been used in protocols addressing hydrogen-predominant SIBO. If you prefer dietary garlic supplementation, crush 3 to 4 cloves of fresh garlic. Let them sit for 10 minutes. This is critical. That resting period allows the allicin-forming enzymatic reaction to complete. Then consume them raw. This is less targeted than the supplement form, but has genuine supporting evidence and is far more accessible. The fourth intervention is dietary modification, specifically the modified elemental approach during the active treatment phase. I am not going to recommend that you permanently eliminate foods, because that is not the goal and it is often not sustainable. But during the 4 to 6 weeks of active antimicrobial treatment, reducing the substrate available for bacterial fermentation dramatically increases the effectiveness of the protocol. The foods that ferment most rapidly and extensively in an SIBO-affected small intestine fall into categories that researchers have labeled FODMAPs: fermentable oligosaccharides, disaccharides, monosaccharides, and polyols. The FODMAP concept emerged from research at Monash University and represents some of the most rigorous dietary science in this area. Rather than giving you an overwhelming list of forbidden foods, let me give you the practical application for this specific phase. For 4 weeks, significantly reduce but not necessarily eliminate wheat and rye products which contain fructans, onion and garlic in their whole forms. Interestingly, garlic-infused oil, where the garlic has been removed, does not contain the fermentable compounds. Legumes, including lentils, chickpeas, and black beans. Lactose-containing dairy, specifically regular milk, soft cheeses, and ice cream. Hard, aged cheeses like cheddar and Parmesan have very low lactose content and are generally well tolerated. Apples, pears, and mangoes in large quantities, and foods containing high fructose corn syrup or sorbitol, which appear on labels as sweeteners in many processed foods. What you can eat freely during this phase: rice, quinoa, and oats. Most vegetables except the high fermentation ones like artichokes, Brussels sprouts, and cauliflower. Bananas, blueberries, and strawberries. Eggs, meat, fish, and poultry. Hard cheeses, and lactose-free dairy if you tolerate dairy at all. This is not a life sentence. This is a 4 to 6 week treatment window. After the antimicrobial phase, you reintroduce foods systematically, one category at a time, with 3 to 5 days between introductions to assess your response. Write it down. Your notes during this reintroduction phase will tell you more about your specific gut than any food sensitivity panel ever will. The fifth intervention is gut lining repair, and this is the piece that most people, and honestly many practitioners, skip entirely. If the small intestinal lining has been damaged by months or years of bacterial presence and the villi have been compromised, then reducing the bacterial overgrowth is only half the job. You also have to give the lining the materials it needs to regenerate. The enterocytes, the intestinal lining cells, have a relatively rapid turnover rate of 3 to 5 days under normal conditions, which is actually good news. It means the gut can heal faster than most other tissues, if given what it needs. L-glutamine is the primary fuel source for intestinal enterocytes. The cells lining your gut use glutamine preferentially over glucose for energy production. Supplementing with 5 grams of L-glutamine powder. This is a tasteless powder that dissolves readily in water. In approximately 8 ounces of water on an empty stomach in the morning, for a minimum of 4 weeks, supports rapid enterocyte regeneration. Research from Massachusetts General Hospital on post-infectious gut permeability found that L-glutamine supplementation significantly reduced markers of intestinal permeability in patients with compromised gut barriers. 5 grams in the morning on its own, not with food, for maximum absorption. Zinc carnosine is a compound, not just zinc alone, with specific evidence for intestinal lining repair. A dosage of 75 milligrams once daily with food for 8 weeks has been shown in clinical trials to reduce markers of gut permeability and accelerate mucosal healing. This is a specific form, zinc carnosine, not generic zinc supplements. The carnosine component appears to provide a protective and restorative effect on the gastric and intestinal mucosa beyond what zinc alone provides. Slippery elm bark and marshmallow root are two herbal demulcents, compounds that coat and soothe the intestinal lining. They are not antimicrobials. Their role in this protocol is protective. They form a gel-like coating over the irritated intestinal wall, reducing inflammation, reducing bacterial adherence to the wall, and providing mechanical protection while the underlying tissue heals. 1 teaspoon of slippery elm powder mixed into a cup of warm water or oatmeal once daily in the morning, consumed 15 minutes before anything else, over 4 to 6 weeks. Now, a question I want you to think about and answer in the comments. Has anyone in your life, a family member, a close friend, told you they just have a sensitive stomach, that bloating is just part of who they are? How long have they believed that? Because one of the things I find most heartbreaking about this condition is how many people have simply incorporated it into their identity. I have a delicate system. My digestion has always been difficult. This is just how I am. Drop a comment and tell me if this sounds like someone you know. And please share this video with them, because that resignation they are feeling is not inevitable. Let me give you a concrete week-by-week framework so you can see how this all fits together. Week 1 through Week 2. This is the foundation phase. Your primary focus in this first 2 weeks is establishing the structural conditions that allow the protocol to work. Stop snacking between meals. Space your 3 meals at least 4 to 5 hours apart. Begin the apple cider vinegar pre-meal ritual. 1 to 2 tablespoons in 8 ounces of water, 10 to 15 minutes before each meal. Begin the ginger tea once in the morning between breakfast and lunch on an empty stomach. Begin the L-glutamine in the morning, 5 grams in water before your first meal. Begin the modified dietary approach, significantly reducing the high FODMAP foods while eating freely from the tolerated list. Do not start the antimicrobials yet. Your body needs this first 2 weeks to begin the basic structural shifts before the bacterial die-off that the antimicrobials will trigger. A note on die-off, because this is important. When antimicrobials kill large quantities of bacteria rapidly, the dying bacteria release cellular contents, including LPS, and this can temporarily increase systemic inflammation. Some people feel noticeably worse in the first 3 to 5 days of the antimicrobial phase. Increased fatigue, headache, temporarily worse bloating, mild flu-like sensations. This is sometimes called a Herxheimer reaction, named after a physician who described this phenomenon in treating syphilis with early antibiotic compounds. It is not dangerous, but it can be discouraging if you do not know to expect it. If this happens to you, reduce the antimicrobial dose by half for the first week and build up to the full dose in week 2. Drink additional water, 3 liters daily during the active antimicrobial phase, to support the kidneys and liver in clearing these breakdown products. Weeks 3 through 6. This is the active treatment phase. Add the enteric-coated oregano oil, 2 capsules twice daily with meals. Add the berberine, 500 milligrams twice daily with meals. Add the zinc carnosine, 75 milligrams once daily with your largest meal. Add the slippery elm bark preparation in the morning. Continue everything from the foundation phase. Continue the modified diet. This is the most intensive period of the protocol, and it is also the phase where most people begin to notice genuine change. Priya, the patient I told you about earlier, noticed her bloating had dropped by roughly 60% by the end of week 3. Many people experience their most significant improvement in this window. The ginger tea bears one more mention here in the context of this active phase. You can prepare a larger batch. Make 2 to 3 days worth at once. Use roughly 3 to 4 inches of fresh ginger root, grated or thinly sliced, to approximately 6 cups of water. brought just to a simmer for 10 minutes rather than a full boil, which can degrade some of the active compounds. Then remove from heat and steep for a further 20 minutes. Strain, store in the refrigerator for up to 4 days. Warm individual portions in a saucepan rather than a microwave if possible. Consume 1 cup between breakfast and lunch and another between lunch and dinner. If you want to add flavor, a small amount of lemon juice after steeping is pleasant, and the vitamin C may have minor additional benefit for gut barrier function. Weeks 7 and 8 are the reintroduction and assessment phase. Stop the oregano oil after week 6. Do not run it for more than 6 weeks continuously. You can continue berberine for a further 4 weeks if your response has been good, then cycle off for a month. Begin reintroducing the higher FODMAP foods, 1 category at a time, every 3 to 5 days. Start with something relatively low on the fermentation spectrum, a small serving of legumes, for example, rather than jumping straight to wheat. Note your response in your bloat diary. You will learn in this phase which foods are genuinely problematic for your specific gut versus which were only triggering reactions because of the SIBO. Many people discover that their food intolerances dramatically reduce or disappear once the overgrowth has been addressed. Something I have seen consistently in patients who work through this protocol is that they approach week 7 with a kind of cautious disbelief. They have been managing symptoms for so long that the absence of symptoms feels unfamiliar. I want to name that directly. If you start feeling better, please do not immediately test the limits out of excitement or skepticism. Give your gut the full reintroduction timeline. Do not eat half a pizza on day 45 because you are feeling good and want to see what happens. Incremental reintroduction is not timidity. It is data collection. The goal at the end of this process is not just to feel better temporarily. The goal is to understand your specific gut well enough to maintain that improvement indefinitely. What about testing? I want to address this directly because many people ask me whether they should get tested before starting a protocol like this. The standard test for SIBO is a lactulose or glucose breath test, which measures the hydrogen and methane gases produced by bacteria in the small intestine after consuming a sugar solution. These tests are widely available, reasonably affordable, and when performed correctly, they can provide useful information. However, and this is an important caveat, they have a meaningful false negative rate. Research suggests the sensitivity of lactulose breath testing for SIBO ranges from approximately 30 to 70%, depending on the study, which means that a negative test result does not exclude SIBO with confidence. Many practitioners, including some I deeply respect, treat clinically based on the symptom picture even in the absence of a positive breath test. If you can access breath testing and your insurance covers it, or the out-of-pocket cost is manageable, it is worth doing. A positive test confirms your clinical picture and can help your doctor guide treatment. But a negative test should not end the conversation if your symptom pattern fits and the bloat timing test is pointing to small intestinal fermentation. Symptoms are data. They are not nothing just because a test came back within normal range. You might be wondering how this connects to what I said earlier about the gut-brain axis. Here is the link. As the bacterial overgrowth resolves and the intestinal lining begins to heal, the source of the chronic low-grade LPS-mediated inflammation reduces. The brain fog lifts, not always immediately, sometimes over several weeks, but the cognitive clarity that many SIBO patients describe after successful treatment is not placebo. It is the neuroinflammatory load decreasing. Patients who have dealt with persistent low-level depression, difficulty concentrating at work, or a general sense of mental heaviness that they have never been able to explain to their doctor, sometimes find that it improves substantially as their gut heals. The connection is real. The physiology is documented, and it is exactly the kind of thing that would never come up in a 7-minute appointment focused on billing codes. I want to talk briefly about probiotics because the question of whether to take them during SIBO treatment is genuinely complicated, and I think the nuanced answer is more useful than a simple yes or no. The reflexive instinct is to add probiotics when gut bacteria are a concern, but in active SIBO, adding more bacteria to an already overgrown system is not always beneficial. In fact, some research has shown that certain probiotic strains can temporarily worsen SIBO symptoms, particularly if the small intestine is still heavily colonized. The risk is not severe, but it is real. My general guidance is to hold off on probiotics during the active antimicrobial phase, weeks 3 through 6. After week 6, when you have reduced the overgrowth and are moving into the reintroduction and healing phase, then begin a probiotic. But choose thoughtfully. Not all probiotics are equal, and the marketing in this space is aggressively misleading. Look for products containing Lactobacillus rhamnosus and Lactobacillus plantarum. These specific strains have the most published clinical evidence for positive effects on gut barrier integrity and post-dysbiosis recovery. Saccharomyces boulardii, technically a yeast rather than a bacterium, has excellent evidence for supporting gut recovery after antimicrobial treatment and is worth including. A product containing at least 10 billion colony-forming units of these strains, taken once daily with your largest meal, over 8 to 12 weeks, supports the recolonization of the gut with beneficial organisms as the overgrowth is cleared. One final element I want to address is the role of stress and the nervous system in SIBO recurrence, because this is the piece that the dietary and antimicrobial conversation often misses entirely. Chronic psychological stress directly impairs the migrating motor complex through vagal inhibition. When you are stressed, the nervous system shifts toward sympathetic dominance, fight or flight, and digestive function, including the sweeping motility of the MMC, is deprioritized. If you address all the physical elements of SIBO but remain in a chronic state of psychological stress, the recurrence rate will be higher than if you incorporate some form of vagal activation practice. The simplest, evidence-based approach to vagal activation is diaphragmatic breathing. Specifically, 4 to 5 minutes of slow, deep breathing where the exhale is roughly twice the length of the inhale. Inhale for 4 counts. Exhale for 8 counts. This ratio stimulates the vagus nerve through a mechanism involving the intrathoracic pressure changes and the respiratory cardiac coupling that activates the parasympathetic branch of the nervous system. 5 minutes before your largest meal every day for at least 4 weeks. This is not a spiritual practice recommendation. It is a physiological intervention with documented effects on gut motility, and it costs nothing and requires no equipment. Let me bring all of this together as a clear plan. In the first 2 weeks, you are building the foundation. Space your meals 4 to 5 hours apart. No snacking. Begin apple cider vinegar before meals. Begin ginger tea between meals. Begin L-glutamine on an empty stomach each morning. Significantly reduce high FODMAP foods without completely eliminating everything. Start your bloat diary. Practice 4 to 5 minutes of slow diaphragmatic breathing before your largest meal. In weeks 3 through 6, you add the antimicrobials. Enteric-coated oregano oil, 2 capsules twice daily with meals. Berberine, 500 milligrams twice daily with meals. Add zinc carnosine, 75 milligrams once daily. Add slippery elm bark in the morning before food. Expect the potential die-off window in days 3 through 7 and reduce doses if needed. Continue the full dietary modification and the foundation practices. In weeks 7 and 8, begin systematic food reintroduction. Cycle off the oregano oil. Continue berberine for an additional 4 weeks if tolerated. Begin a high-quality probiotic containing the specific strains mentioned. Continue L-glutamine and zinc carnosine for 4 additional weeks. After week 12, reassess. Use your bloat diary as your data. How has the timing pattern changed? How has the intensity changed? What foods have you successfully reintroduced? What, if anything, still causes a significant response? That assessment tells you whether you have fully resolved the underlying overgrowth or whether a second cycle of the antimicrobial phase is warranted. I want to be honest with you about the realistic range of outcomes. Some people, like Priya, see dramatic improvement within 4 to 6 weeks. Others see meaningful but incomplete improvement and need a second protocol cycle, or benefit from working with a functional medicine practitioner or integrative gastroenterologist who can order more specific testing, assess for methane-producing archaea rather than just hydrogen-producing bacteria, and tailor the protocol more precisely. SIBO is not one uniform condition. There is hydrogen-predominant SIBO, methane-predominant SIBO, and hydrogen sulfide-predominant SIBO, and they respond somewhat differently to different protocols. If you do the full 6-week protocol and see less than 50% improvement, that is information, not failure. It is a signal to dig deeper, likely with professional support. What I can tell you with confidence, based on years of clinical experience and the available research, is this. If you are dealing with chronic bloating that the standard system has not adequately addressed, the answer is almost certainly not that your body is uniquely defective and incapable of improvement. The answer is more likely that you have not yet identified the specific combination of factors maintaining your particular version of this problem, and that no one has given you enough time or enough curiosity to find it. The system was not designed to keep you healthy. It was designed to treat you after you get sick. There is a difference. A 7-minute appointment focused on a chief complaint and a billing code was not designed to trace 15 years of bloating to a proton pump inhibitor that never should have been renewed for 8 consecutive years. That kind of investigation requires someone to actually sit with you and ask the full question. That is what this channel is for. I am not going to pretend that a YouTube video is a substitute for a good physician. It is not. But I am going to tell you what I know in as much detail as is useful so that when you do walk into a waiting room, or if you are fortunate enough to have a doctor who actually listens, you are not arriving with vague complaints. You are arriving with a timeline, a bloat diary, a list of questions, and an understanding of why those questions matter, because the person who knows the most about what is happening inside your body is still you. Before you go, one more thing from me. If any of what I have shared today resonated with you, if you recognized yourself in Priya's story, if you have spent years being told your bloating is just how you are, I want to hear from you. Tell me in the comments how long you have been dealing with this. Tell me what you have already tried. Tell me if there is a specific aspect of the protocol you want me to go deeper on. And if you are going to give this protocol a real 6-week trial, tell me that too. I read the comments. I respond when I can, and knowing that someone out there is actually using this information, that is the entire reason this channel exists. I am Nathan Cross. I spent 12 years inside a system that was never designed to give you this conversation. That is why this channel exists. Subscribe, leave a comment, and share this with someone who needs to hear it. The only way this information reaches the people who need it most is if you help it get there.